So I am just absolutely delighted to be able to introduce Professor Mara Bookbinder. She's a medical anthropologist who embodies interdisciplinarity with appointments as professor and vice chair of social medicine in the School of Medicine, adjunct professor of anthropology in the College of Arts and Sciences, and a core faculty in the Center for Bioethics, all of those here at UNC Chapel Hill. A prolific researcher, Dr. Bookbinder has authored or co-authored 3 monographs: Saving Babies, The Consequences of Newborn Genetic Screening in 2012, All in Your Head, Making Sense of Pediatric Pain in 2015, and most recently, Scripting Death, Stories of Assisted Dying in America. And that came out from the University of California Press in 2021. She's also the PI on a new project that examines physician stress during the pandemic, and that's with Health Humanities Grand Rounds alum Tanya Jenkins. So we look forward to learning more about that project. And I would say that what unites her research on newborn screening, pain, medical aid in dying, and pandemic stress is Dr. Bookbinder's focus on how patients, families, and healthcare providers navigate the social and ethical challenges that result from changes in medical technology, law, and health policy. With a keen focus on language and relationships, Dr. Bookbinder's ethnographic research engages in interdisciplinary inquiry and some of the most pressing ethical issues facing biomedicine. Her talk today will focus on ethnographic research that she did for her most recent book, Scripting Death, that revolves around Vermont's 2013 Patient Choice and Control of End of Life Act. Drawing on interviews with patients and providers and participant observation of advocacy groups and professional medical conferences, the book seeks to answer an important and compelling question: how did death become something one does rather than something that happens? Her analysis attends to the consequences of narratives that different groups assign to medical aid in dying, especially narratives that prioritize control and agency over death, all while astutely acknowledging the inequities that aid in dying procedures perpetuate. In all, Dr. Bookbinder is a talented researcher, valuable colleague, and devoted mentor. Anytime that her name comes up here at UNC and beyond, it is accompanied by enthusiasm and praise. So I'm just delighted that she agreed to join us this afternoon to share her work. So please join me in welcoming Dr. Mara Bookbinder to Health Humanities Grand Rounds. Welcome, Mara.
Thank you, Kim. That is one of the most generous and detailed introductions that I have ever received. Thank you so much. I'm just going to share my screen. Okay, so you're probably sick of staring at my book cover by now. I'm going to move on very quickly. I'm really delighted to be here. Thanks for spending this rainy afternoon with me. So I'm going to be speaking to you today about some of the key findings from my book, Scripting Death, which came out last spring, which, oh my God, already seems like a lifetime ago. And as Dr. Reed mentioned, it's an ethnographic account of the implementation of Vermont's medical aid in dying law. And in the United States, what these laws do is they refer to the ability of a physician to write a prescription to a terminally ill patient for a lethal dose of medication for the purpose of ending the patient's life. And I want to make a distinction here from the laws that are in play in Canada and in parts of Europe, where a physician may actually directly administer medication to a terminally ill patient to end their life. So in the US, these are all medications that are self-ingested. So I'm going to start my talk today with a story about a patient whom I call Frances, and all of the names that I'll use in the talk today are pseudonyms. And I met Frances in her home a few years ago. She was in her 60s and she had been living with ALS for a few years. And I walked into her house, which was this like totally gorgeous log cabin that she had planned to retire to with her husband. And she was sitting on the couch waiting for me, and she handed me this note. And I'm going to read it for you in a minute, but it's important to say that she had written this out for me because at this point, the ALS had so severely impacted her speech that she was communicating primarily via iPad. So this is what she said. She said, I've been a critical care RN 1975 to 2015, seen many patients die on respirators, tied down, pleading eyes as I give meds to settle them. But who knows what they were thinking trapped like that, families coming and going exhausted. In acute care, some patients would never go through what was going to happen to them if they had the choice. But once that starts in that setting, there's no going back. They die attached to tubes, feedings, incontinent, no communication, tears sliding from corners of eyes. Many patients and families need to have this option. It's our bodies and lives and should always be our choice. When and how we die is our right. I would advocate for my patients when no hope at all, but would be endless discussions with their team of doctors, then each specialist weighing in, then palliative care, then family meetings, on and on. But the one person left out is the one dying slowly who was never given a choice. And Frances went on to hasten her death using medical aid in dying just a couple of weeks after we met. So I want to start with this note because I think it really showcases a lot of the dominant language that we tend to hear about medical aid in dying in the public debates and in the media coverage of this topic. And this really has to do with these concepts of individual choice and autonomy. But one of the goals that I have for the talk today is to demonstrate that implementing medical aid in dying is much more than a matter of simply respecting individual autonomy. And I hope that that will come through in the material that I'm going to show you. Now, just to give you a bit of background, the legalization of medical aid in dying in the United States has proceeded at the state level, beginning with the passage of Oregon's Death with Dignity Act in 1997. And that same year, two Supreme Court cases rejected the view that there was a constitutional right to die with the assistance of a physician. But they did leave the door open for individual states to authorize medical aid in dying. And we've really seen a dramatic growth in the past couple of years of this practice. The number of permissive jurisdictions is now 11, making this option available to a little more than 1 in 5 Americans. In Montana, medical aid in dying was legalized via a judicial ruling, but there's no regulatory statute in place. And that's why Montana is a lighter shade of teal on the map here. And I want to note that this is really a rapidly shifting landscape. So all of the lighter orange states on the map have introduced legislation during the last legislative session to try to pass medical aid in dying laws. The New Mexico bill was most recently signed last spring. And there are several states with existing laws, including California most recently, who introduced new legislation to modify the existing laws and in most cases liberalize them a little bit to make access a bit easier and eliminate some of the safeguards. So the law that I was studying is Vermont's Patient Choice and Control at End of Life Act, which was passed in 2013. And there's a picture here on my slide of former Governor Peter Shumlin signing the bill into law. And at the time that I started this research, Vermont was actually the state that had most recently legalized medical aid in dying. It was the 4th state. And that was the main reason that I decided to focus on it in my research, because I've really been interested for a long time, stretching back to work that I did on abortion law, in understanding what happens when laws and policies are new and their practical significance is still being worked out on the ground. And so as I started making calls in Vermont, a lot of people said, oh, you really want to go to Oregon for this because they've been doing it a lot longer. And I would have to explain that, no, this is actually why I am interested in coming to Vermont, because there's a lot of really interesting interpretive work that happens when these laws are new. Vermont was the first state to utilize the legislature as opposed to the courts or a ballot initiative process. And Vermonters are quite proud of this fact because there was a really interesting grassroots mobilization that took place to help the law get passed. Of course, just a couple of years later, California also used the legislative pathway. And so I think it became slightly less remarkable when a state as large as California was able to follow suit. But it was sort of an interesting story of how this came to be with the work of several local state-based advocacy groups. So the law itself is pretty similar to laws in place all over the US. It permits physicians to write a prescription for a lethal dose of medication to a mentally competent adult patient for the purpose of ending the patient's life. And the requirements are largely identical to those in place elsewhere in the US. And these safeguards are designed to ensure that the choice for medical aid in dying remains a voluntary autonomous choice, right? So, so this notion that there have to be two physicians to confirm that the patient is eligible and that they're mentally competent. And physician participation is also voluntary as well. In terms of utilization in Vermont, in January of 2018, the Department of Health released a report about the utilization of the law in the first 4 years of its existence, which very conveniently aligned with my research period. So one thing to note here, though, is that there were no prescriptions written in almost the first 18 months since the law was signed. And that is because there was no regulatory Department of Health infrastructure in place. The law was written so that it would be effective as soon as it was passed. And no physicians in the state were comfortable prescribing under those conditions until the Department of Health could kind of catch up with the regulation of the law. So you can see the frequencies are pretty low. Vermont is a very small state. It has a population just over 600,000. There was paperwork filed for 52 patients during this initial time period, and most of these were cancer diagnoses. At the time that the report was filed, 60% of these patients had died as a result of ingesting the medication, which is actually a little bit higher than what we've seen in Oregon, interestingly enough, in terms of the number of patients that go through the process who then actually ingest the medication. There are quite a few who end up kind of saving it as reassurance, but never ingesting the medication. And these numbers really didn't rise very much in the subsequent 2-year reporting period. So this second set of numbers is from the second public report that was released. And I like to show these statistics because I think it highlights that it's really only going to be a very small segment of American society that's likely to experience this sort of death for themselves. But I think that at the same time, the cultural impact of medical aid in dying really stretches much further than these numbers might suggest, because it tends to be discussed a lot more than it's actually performed. And it can serve as a gateway for other kinds of discussions about values and preferences at the end of life. And so I think there's a way in which it changes the broader public conversation about control over dying. So the study that I did was called the Vermont Study on Aid in Dying, or Vermont SAID, and I used qualitative descriptive data that I collected between 2015 and 2017 to address these 3 primary questions. So first of all, how do ordinary people understand, access, and contest medical aid in dying once it's legally authorized? How do healthcare providers, medical institutions, and policy stakeholders accommodate or resist medical aid in dying as a new end-of-life practice? And what are the ethical challenges for clinical communication and the patient-clinician relationship? And I'm interested here in nurses and allied health professionals, as well as physicians. My primary methods have included 144 semi-structured interviews, and all but 3 of these were conducted in person. Almost all of them were audio recorded. A couple of people opted out of that. And I also did observations in conferences for Vermont healthcare providers, in some public events organized by advocacy organizations. So I have some photos here from the Wake Up to Dying project, which was a public installation that occurred during the time of my research over several summers to kind of foster public conversation around the notion that all of us will die someday. And I volunteered in those events and attended some of the educational sessions there. And then there was also a judicial hearing. There was a lawsuit challenging the law that took place during the time of my research, and I attended the judicial hearings for that as well, and kind of followed the lawsuit as it evolved. It was ultimately dismissed. So one of the benefits, I think, of looking at this phenomenon in a state like Vermont is that I really was able to talk to most of the key players because it's such a small state. I was able to interview a majority of the prescribers at the time of the research, and also many of the key policy stakeholders like legislators and activists. And the circles on the map indicate places where interviews took place, with the larger circles representing a larger concentration of interviews. And I like to show this because I think it's important in the sense that this phenomenon looked really different in different parts of the state. So access to physicians willing to prescribe varied quite a bit. And so I think if I had only done this research in Burlington, which is kind of the biggest city and the largest metropolitan region, I might have gotten a very different sense of what medical aid in dying in Vermont looks like. The sample was all white, which is important to note. Vermont is a very white state, so this is not entirely surprising, but the sample was 95% white. So before I turn to the data, I want to share a few thoughts about some of the central organizing concepts for the book, starting with this idea of control. And there's really a sizable literature now on expanding human control over death. But these studies have often been framed in terms of the relationship between technology and nature, and this notion that, that technology represents a threat to natural death. And this has led to debates about the boundaries between life and death and the prolongation of life through biomedical technologies. As I think Dr. Weed mentioned in the introduction, technology kind of makes it possible for death to become something that we do rather than something that happens to us. And so from one perspective, I think it might be tempting to view medical aid in dying as offering some kind of salvation from technology in this sense. But I think it's a mistake to see the assisted death movement as simply a reaction to the growth of medical technologies. And I'm drawing here on the work of the historian Shai Lavie, who has actually shown that efforts to legalize euthanasia in the United States can be dated back to the early 20th century and actually preceded the advent of contemporary biomedical technologies. And Lavie argues that the growth of life-prolonging technologies and the euthanasia movement are actually both products of this broader Enlightenment desire to master the dying process, to seek control over the dying process. In addition, in seeking to avoid a heavily technologized hospital death, it's not only the trajectory of illness that is subject to control, so the kind of the length of that terminal trajectory, but also the personal and cultural meanings of death. And I think this is a way in which medical aid in dying can be differentiated from other attempts at controlling death, such as writing advance directives, because one of the things that I hope to show you today is that medical aid in dying really enables people to infuse their deaths with a lot of personal meaning and to think about who they want with them and where they want to die and all of those sorts of things. So if control represents the desired effect over death, I think agency is sort of the pathway through which it's realized. And I define agency broadly as the capacity to act with intention. For anthropologists, agency is always located within larger social relations and systems of power. And it's closely related to the bioethical concept of autonomy, which is the ability to make decisions about one's body and the freedom to do so. But I think that agency is always socially embedded, and it's conceptualized in relation to the social structure. Whoops. Wait a minute, sorry. Okay, and this social embeddedness and this relationship with power, I think, is part of what distinguishes this social scientific concept of agency from bioethical formulations of autonomy. And with medical aid in dying, both agency and control over death are distributed amongst a range of actors and institutions. Scripting death is both the title and the central organizing concept of my book, and it refers to this really powerful cultural desire for control over dying in American society and also elsewhere in many other societies around the world. This desire to script death is not universally shared, but it's shaped by social factors like religion, race, and class, by individual characteristics like personality and family background, and by circumstances like diagnosis and prognosis. And I think there are different avenues available for scripting death, including non-medical ones. But many who seek to script their deaths actually want the cultural legitimacy of a legally and medically authorized type of death that might not be available through other means. I use the term aspirational death to signal the aesthetic, affective, and ethical preferences that inform orientations to dying as a matter of personal choice and careful choreography. And this term also conveys this sense that the desired type of death might not be attainable. And this was a really important theme in my research as well, because one might live in a state where medical aid in dying is not legally authorized, or one might not have a diagnosis or prognosis that makes one eligible for medical aid in dying, or one might not be able to find a physician that is willing to write the prescription. So one of the questions that's really interested me in this work is, what happens when death becomes an object of desire that somehow remains out of reach? And that's part of what I'm conveying with this notion of aspirational death. My use of the term scripting also plays on several distinct meanings of scripts, including norms or expectations for behavior, protocols and procedures that order work processes and institutional practices, and written documents such as written prescriptions for medication. Scripting also encompasses staging or choreographing death to fulfill preferences about how, when, where, and with whom one dies. At the same time, because scripts only go so far in determining action and events, I think the concept of scripting also invites questions about how people might improvise when there's not a script or when things do not proceed as expected. So with my remaining time, I want to share a few examples with you about how this scripting works, first from the perspective of physicians and then from the perspective of patients. Okay, so first, the physicians. It's a lot of responsibility and power to give people a script that they can end their life with. This was a statement that was uttered by Dr. Alana Reynolds, which is a pseudonym. She was a hospice and palliative care physician and that I interviewed. And she went on to tell me about how, as a hospice medical director, she felt the need early on to take some sort of a stance after the law was passed, yet also support a diverse set of opinions about it because it was such a polarizing issue. And so this left her in a bit of a quandary, but she decided that really what was most important to her was to truly understand her patients and what was motivating them. And she had a series of intimate conversations with a few patients, some of which really challenged some of her previously held views about medical aid in dying. And she ended up really supporting it for the right patient, is how she put it. And I like to start here because I think her experience was typical in the sense that many of the physicians that I encountered were not either starkly for or starkly against assisted death in the aftermath of legalization. And that's often the way that I think the scholarly literature portrays it, and sometimes even the media narratives about medical aid in dying often portray it in that way, that physicians are either for or against it. But I found that more people were sort of like Dr. Reynolds, where they had nuanced and often ambivalent feelings that evolved over time through some of their direct patient care experiences. Of the 29 physicians that I interviewed for this research, 19 had participated in medical aid in dying in some capacity. And this table provides some more information about their specialties and demographics. But those physicians who had direct experience with medical aid in dying were roughly split between hospital and community-based practices, with most specializing in internal or family medicine. Their mean age was about 51, and most of them were female. And 12 had participated as prescribing physicians, with the rest either initiating but not completing the protocol, or participating as a certifying physician to confirm the diagnosis and prognosis and decisional capacity, or some had just counseled patients about this option, but not actually participated in any of the the formal processes for the law. One of the things that really stood out to me in my review of the literature is that most of the prior studies of physicians' interactions with medical aid in dying have really focused on their willingness to prescribe or how they might respond to a patient request. And what I found is that there was actually a wider range of ways in which physicians might engage with medical aid in dying, beyond simply responding to a request or deciding whether or not to prescribe. And importantly, even if they decided not to prescribe, the physician might participate in other domains of care. So I identified 5 domains of physicians and nurses' participation in this practice. Clinical communication obviously entailed exploring the patient's reasons for pursuing this, probing for alternative means of addressing these reasons. In terms of the protocol, the providers often emphasize that understanding the law itself is a time-consuming process, and there was a lot of bureaucracy that went along with it. Of course, prescribing was one way that they might engage with medical aid in dying, but it was far from a one-time event of writing a script, and often entailed consultation with other physicians and pharmacies to try to discern what the best medication protocol might be. And then many of these providers engage deeply in planning for the patient's death and making contingency plans in case things didn't go as planned, and sometimes in actually attending the death as well. And then finally, several physicians expressed a commitment to educating colleagues about the process, whether formally or informally, because there was still, at the time of my research, quite a lot of misinformation and misunderstanding about the law and about some of the clinical aspects of medical aid in dying as well. So one of the big questions that I address in the book is about the personal and professional meanings of what it's like for physicians to participate, and the extent to which medical aid in dying can be reconciled with traditional medical practice. So the question for me was, to what extent does the act of writing a script for a lethal medication align with the physician's professional role as a healer? And I think it's really important to note here that physicians, and especially the American Medical Association, have historically been some of the strongest opponents of the legalization of medical aid in dying in the US, due to concerns about the Hippocratic Oath and this commitment to do no harm, right? And so the AMA has said that this is fundamentally incompatible with the physician's role as healer. But medicine is a very heterogeneous space, and many physicians disagree with this view. And in the past few years, especially, many professional medical societies have moved from a position of opposition to one of neutrality. In palliative care in particular, some physicians have argued that medical aid in dying does align with the objective of relieving suffering and the values of patient choice and patient choice and non-abandonment. So among my study participants, the significance and meanings of medical aid in dying for the physician's professional role really varied quite a bit, even among those who participated and actively supported the practice. So I want to turn to a few cases now to illustrate this. Dr. Lena Rhodes had worked as a hospice and palliative care physician for 11 years in a small rural community. She had been drawn to this area of medicine after experiencing several significant deaths in her 20s, and she had navigated the medical aid in dying protocol with 4 patients, 2 of whom ultimately ingested the medication. When it first came up, she was surprised by her ambivalence. She viewed prescribing as a tremendous moral and emotional responsibility, and she did not take the decision lightly, but she understood the patient's choice, and she thought it was really rational for that patient because it reflected the way that he had lived his entire life. Moreover, she was committed to non-abandonment, was convinced that if she didn't write this prescription, he would end his life in a much more gruesome manner. So for Dr. Rhodes, the moral and emotional burden of medical aid in dying was a critical part of the practice. She thought it was supposed to stay hard to protect against abuse. She resented those who viewed her participation as somehow a denigration of the physician's professional role, and felt that these people did not understand the thought and care that went into this work for her. So Dr. Rhodes is one of the physicians who really saw this work as a departure from ordinary clinical medicine. And she found it incredibly emotionally consuming. And it was something that she really didn't take lightly, but she considered it a necessary expression of her commitment to non-abandonment and her commitment to her values for clinical care. Dr. Wright's perspective provides an interesting contrast to that of Dr. Rhodes. So he had worked as a family physician in a rural community for 20 years and as a medical director at a hospice and home health agency for the past 8. And he had also been board certified in hospice and palliative medicine for several years. So Dr. Wright used to believe that assisting death was not part of his role as a physician. But his hospice work had really taught him that there was sort of a fine line between what he did in aggressive palliative care, that's how he put it to me, and actively giving patients medication to terminate their lives. So he saw this as kind of a fuzzy boundary. So he had become a vocal supporter of medical aid in dying, and he had prescribed a handful of times and counseled a larger number of patients who had approached him for this. And he had also entertained referrals from physicians who were unwilling to participate. So he kind of became known amongst colleagues as, if you're uncomfortable with this, you can refer to Dr. Wright and he'll be willing to help. And when I asked him to reflect on his role in medical aid in dying, he said that he really considered it on the spectrum of palliative care once we've decided that death is inevitable. He also articulated really a sense of pride in being able to provide this highly valued service that many of his colleagues were unwilling to offer. So for Dr. Wright, participating in medical aid in dying was not substantially different from other aspects of his professional duties. It was on the spectrum of ordinary palliative care, and it was an aspect of his clinical work that he was quite proud of. So when we compare his work to that of Dr. Rhodes, it's clear that these two physicians are going to be affected by assisting a patient in quite different ways. Dr. Wright feels proud, he doesn't feel an emotional burden, whereas Dr. Rhodes finds it quite emotionally draining. Now I'm going to introduce the third case. Dr. Jones was a hospice and palliative care physician whose clinical work has split between primary care and palliative care consultations. When a patient asked her whether she would be willing to prescribe under Act 39, Dr. Jones felt conflicted. On the one hand, because she strongly believed in the capacity of hospice and palliative care services to provide excellent care for dying patients, she was at least partially inclined to view such requests as a cop-out pursued by patients who had not truly exhausted all of their options. On the other hand, Dr. Jones was committed to the ethos of patient choice and didn't want to abandon her longtime and much beloved patient at this really difficult time. So Dr. Jones ultimately decided that the best way to navigate these conflicting values was to do everything possible to help her patient, short of actually writing the lethal prescription. She saw this as kind of crossing a moral line in the sand. So she assisted in identifying a physician willing to write the prescription. She agreed to be the consulting physician, certifying that the patient met the legal requirements. She worked with the prescribing physician to plan, and she made sure that contingency plans were in place for the day of the patient's death. So Dr. Jones objected to medical aid in dying, yet its existence as a legally authorized option made her feel some sense of responsibility to help her patients pursue it if they desired it. And this was really interesting to me, in part because the bioethics literature tends to characterize physician stances as either starkly for or starkly opposed to morally contested services like medical aid in dying or like abortion. And Dr. Jones's solution relied on this distinction between indirectly helping the patient and directly contributing to her death. And she recognized that this distinction was really tenuous, but it allowed her to reconcile her opposition to this choice with her deeply felt personal and professional obligation to help her patient receive the kind of care that she wanted. And this was some nuance that I really have not seen much of in the literature, where it's often assumed when we think about physicians' conscience and the notion of conscientious objection, it's often assumed that people are either kind of purely for or against. So I think these cases show that there are multiple ways that physicians can contribute to scripting deaths that don't necessarily involve a script pad. And these might include having intimate clinical conversations about a patient's hopes and desires, advising about the timing of death, and planning for adverse events. And these diverse forms of clinical action showcase physicians' agency and improvisation in the processes involved in scripting death. So now I'm going to shift gears and tell you a little bit about the idea of scripting death from the patient's point of view. And then we'll have some time for questions and discussion. So one of the richest and really most interesting parts of this study for me has been getting to hear about how patients plan and even choreograph their deaths when they have the opportunity to do so. And this is a photograph of Betsy Davis. She was a 42-year-old woman diagnosed with ALS who chose to die using California's End of Life Options Act back in 2016. So this took place in California. This was not part of my study. But Betsy invited friends and loved ones to attend a 2-day rebirth ceremony. And that's the language that she used to describe this. She died on the side of a hill as the sun was setting, which was her choice. And she was surrounded by family and friends. And I find this photograph so interesting because to me, it really resembles nothing more than a wedding, right? With sort of the way people are dressed up and they're in these white folding chairs. And I think it really highlights these ritualized elements that these scripted deaths can take on. So Betsy's death was sort of an extreme example. I didn't encounter anything like this in my study, but there were some common elements that I encountered in the stories that I heard about medical aided dying. And these included the presence of close family and friends, a sacred atmosphere, though this could range from joyous to more somber. A ritual element like a final toast was very common. And finally, they all took place in a domestic or non-medical setting. And this is really important. And in Vermont, these deaths are all happening at home because there is a stipulation in the law that permits hospitals and skilled nursing facilities to prohibit patients from ingesting life-ending medication on their premises. And almost all of the medical institutions in the state have taken this policy on. I think there's one continuing care retirement facility that does enable people to use medical aid in dying on their premises. But this means that death is happening entirely in this domestic space. So one of the key questions that really interested me in the book, and that I think we can see reflected in this photograph, is how does the emergence of this aspirational form of death transform our understandings of the kind of death that the kind of event that we understand death to be, right? And how does this new way of dying sort of alter the landscape of death and these scenes of death? And one of the things that I argue in the book is that medical aid in dying really turns death into an event, which is to say that it becomes this anticipated, highly choreographed occasion that can be planned and staged and produced. And so it transforms death into kind of an inchoate experience that a terminally ill person passively awaits to one that they actively craft and manage and shape and produce. So there becomes this important distinction between waiting to die and actively making death. One of the points that I make in the book that I am not going to have time to go into here is that this opportunity to make death and to achieve an aspirational death is not evenly distributed. And it's an option that is not equally available to everyone because of multiple barriers that terminally ill people might face in attempting to access this form of assisted death. So So there's almost like this inflection of privilege that comes into play with these deaths because they're not accessible to all. So I'm going to tell you now about some patients that pursued assisted death. In July of 2016, I sat on the porch of Clara Barnstable's home drinking tea. Her father, Arthur Rivers, had died earlier that year following a lung cancer diagnosis in his early 90s, and Clara was recounting his choice to end his life using medical aid in dying. Prior to his death, I had met and interviewed Arthur, who was a retired business executive, and his wife, Bea, about their activism for medical aid in dying. And together, they had helped to form a grassroots advocacy group that retained a political lobbyist and helped to get Vermont's medical aid in dying law enacted. So Clara explained to me, typically with cancer, you have two choices. You can choose aggressive treatment, or you can let the disease take its course and rely on morphine for pain management. But with that latter option, she said, you're basically making a decision to be out of it because of the drugs. And that's not what her father wanted. So she said, if you have the alternative to, choose the time of your death, then all the other discussions are different. And it's really hard to put your finger on it until you've seen it. But the whole nature of the discussion is different. It's about, well, what are the key things you want to be doing in the last months of your life? And my dad said, I want to be sailing. I want to be sailing on Lake Champlain. And he did. So according to Clara, choosing the time that you die changes the stakes of how you live the end of your life. And Arthur Rivers took his last sail a month before he died on Lake Champlain, which is pictured here in this photograph that I took. And in his last week, he entertained visits from family, colleagues, friends, and had what Clara later described as some of the most meaningful conversations of his life. For Clara and Arthur, a key tenet of this new way of orienting to death was that making death changes the end of life. So for Arthur, it was imperative to go out sailing, to continue to experience a desired quality of life until the very end. And his aspirations to be sailing in the last months of his life were quite literal. He was an avid outdoorsman, and sailing is one of the activities that he had enjoyed throughout his retirement, even as he slowly gave up some of the more rigorous forms of physical activity that he enjoyed. But I think sailing here is also an apt metaphor for thinking about this concept of agency over death. Because on the surface, it might appear that the wind is kind of just carrying the boat. But sailors are not simply moved along. And this is the term that the anthropologist Sharon Kaufman has used to talk about how dying people are driven by hospital bureaucracy as they approach death. And they're sort of just moved along in this series of interventions and series of technologies. But sailing demands careful control of the sails and the rudder. Sailing like dying can be slow and unpredictable. And sailors are always acting with intentional movements and subtle corrections, even when it seems that they're just letting the wind carry them. At the same time, the person sailing the boat never acts alone. The boat has to be in good working order. The wind and weather conditions have to be right, and the sail has to be properly rigged. And so I think this is another way of saying that the structural conditions have to also be suitable. So I think that this metaphor of sailing can help us to see how Arthur Rivers exemplifies the structures of power and privilege that made it possible for him to launch a grassroots social movement in Vermont to legalize medical aid in dying that actually enabled him 12 years later to attain a particular kind of aspirational death. It's really quite a remarkable story that he got this law passed and then he used the law. Arthur had begun his efforts one winter when he needed to get his knee replaced, and he told Clara, we're not going to be able to go out west and go skiing all winter, so can you help me draft this law? I've talked to some legislators and we'll get it passed this year, and then next year we'll go skiing out west. And in retrospect, this timeline amused Clara because the law did pass, but it took 12 years to do so. And several years after that, Arthur completed the paperwork and then used the law himself. He chose the day of his death for practical reasons. It was based on the availability of a trusted physician that he wanted to attend his death. And in his last week, he got more and more directive. He wanted to have his last stamp on things, is how Clara put it. He dispensed advice to family members and people he had mentored, and he helped to craft a press release about his death. And then he and his wife hosted a final dinner with friends. And then on his final morning, Arthur attended to a number of practical issues, signing paperwork regarding his plans to donate his body to the medical school. And then finally, before taking the medication at home, Clara said they toasted with bourbon and kind of sent him off with lots of sailing analogies, setting out to sea, that sort of thing. It was joyful and peaceful, and it's exactly what he wanted. So I think Clara's recollection of her father's last days reveals a transformation in how we understand death. Arthur carefully scripted his death to live the way that he wanted to for his last days and to take care of the final arrangements. The day of his death revealed a combination of the joyful, so gathering family, toasts, stories, to the mundane, things like paperwork and bureaucracy, with Arthur really maintaining constant control of his environment and the people surrounding him. And what was at stake for him here, I think, was not simply a desire to tame uncertainty, but a new way of reckoning with mortality and envisioning death in this aging society. And ultimately, his death marked the culmination of years of advocacy work and hard work to attain an aspirational death. Now, I have a couple of more cases, but I'm running a little bit short on time, so I think I'm going to skip ahead because I want to make sure we have time for questions. But what I kind of wanted to highlight with these cases is that medical aid in dying, as we saw with Arthur, is really an intensely social practice. And this was surprising to me, in part because the dominant advocacy discourses around medical aid in dying highlight autonomy and the desire to escape dependency in the final stages of illness. And this is a paradox that I talk about in the last chapter of my book. But what I saw is that there was actually a forging of new forms of sociality around assisted death, even as people were trying to escape dependency. And this was marked by the fact that patients were all choosing to die at home, as I mentioned. Nearly every patient that chooses to die with medical aid in dying is not alone at the time of death. And this is partially because of the assistance needed in preparing the medication, but I think it's also because people, for the most part, want to be with others at the end of life. And there's a way in which assisted dying provides caregivers with similar opportunities to make death by stage managing and helping to produce these deaths. The others that were present for death were not exclusively family members. This was really interesting to me. There's a lot of kind of worry these days about how families are spread out, and this leaves older adults isolated without people to take care of them. But I was really pleased to see, at least within my small sample, that people were often cared for by friends in the final stages of illness. So I don't want to suggest that isolated elders don't exist, but rather to say that these people that were choosing medical aid in dying were not choosing it because there was no one to take care of them. And then finally, choosing to die using medical aid in dying enabled planning to make the death personally meaningful by infusing it with ritual elements and sacred meaning. And together, I think that these factors resulted in a more engaged role for loved ones in shepherding death than many of us will really otherwise face. Okay, so my conclusion. The notion of scripting death helps to distribute agency and control over death across a larger system of actors that included the patient, her caregivers, physicians, and the state. And it is this distributed agency that enables Dr. Wright to see himself as assisting death and assisting patients in accomplishing their goals, but not actually authoring these patients' deaths. And Dr. Jones to make a distinction between indirectly helping the patients end her life and directly contributing to her death. Many people view the textual act of writing a prescription or a script, as it's referred to in medicine, as the defining feature of the physician's role in medical aid in dying. But the physicians in my study did not necessarily view this as the most significant or even the most morally laden aspect of the clinical work that they did with medical aid in dying. So I think that public dialogue that reduces their participation to the willingness to prescribe or not overlooks the diverse possibilities afforded by these different modes of assistance and care, and how they construct physician agency with respect to scripting death. So together, these cases really preserve a space for ambiguity, uncertainty, and complexity in thinking through the implications of medical aid in dying for the physician's role. Scripting death also enables the dying person to reclaim agency over the dying process and become the producer of their own death. And people approach this with a range of dramatic sensibilities, from moments of comic relief to more of a somber atmosphere. My findings also reveal an important role for caregivers and loved ones in choreographing death, an issue that I think is largely missing from the public conversation on medical aid in dying in the US. But I think that while medical aid in dying can be seen as offering an aspirational death, there's a little bit of a danger in the potential for what I see as an aestheticization of death. So that turning these deaths into kind of clean and sanitized deaths, which is sometimes what people are after, the avoidance of bodily fluids, that can have the unintended consequence of making some deaths seem more meaningful and valued than others. So not everyone who dies in a permissive jurisdiction will have the opportunity to plan for death, meet the other eligibility requirements, and overcome access barriers. And some patients and families may need support to create a meaningful death at home. Nevertheless, for those who are able to avail themselves of this option, hastening death under the framework of legalized medical aid in dying can really transform death from a messy and unpredictable process into a staged event. With that, I'll just acknowledge my funders and my research assistants. And I hope I've gone on a bit longer than I wanted to, but I think we have time now for some questions.
Thank you so much for that incredible overview of your incredible book. So we're just all so grateful for this. Folks, as a reminder, you can type a chat or question into the chat, or you could use that raise hand feature to ask a question of Dr. Bookbinder. And as folks are collecting their thoughts, Mara, are you comfortable going just a couple of minutes over our 5 o'clock time if we've got the questions? Cool. Absolutely. All right. Yeah, folks, what do you want to know more about?
I saw that, is it Roten had their hand up? I don't know if I pronounced that correctly. Do you still have a question?
Oh, no, I don't.
That? Oh, that may have been a hand clap. Yeah. Well, I might, if it's all right with you, kick things off with a question about this relationship between death and birth. I think that example of the rebirth ceremony really kind of illustrated how closely connected those two things are. But I also see the way that this desire to sanitize and control death to me seems kind of parallel to attempts to control birth. I'm thinking of all the carefully planned and scripted birth plans, I mean, that often frankly go out the window the moment that labor begins. And knowing that you've done some work in addition to this book on reproductive health and newborn screening, if there are ways that the discourse in particular about control overlaps between birth and death, or is this really something quite distinct from that?
Yeah, it's something that I've thought a lot about, and I think there's a tremendous amount of overlap. I mean, there's one part of the book where I actually write about attending a death planning workshop, and the activities reminded me a lot about planning for birth. And at the time of the research, I had a fairly young son. He's a little bit older now, but that was fresh in my mind, this notion of creating a birth plan. And I talk in the book about how I was really opposed to the idea of creating a birth plan. And so I was a little bit opposed to the idea of creating a death plan, I think, because of that. And I think a lot of that was my medical anthropology training sort of reminding me that these plans are sort of often a container for our anxiety and a way of trying to artificially, have some sense of control over the uncontrollable. But I think they're so similar in that sense. There are maybe some differences because there's a big gender story with birth, and with the way that women are often feel very disempowered in medical contexts, and there's less of that gender story at play with death. But I think that the processes are very similar, and I'll just stop there. But yeah, it's something that I'd like to do more exploring of even.
Yeah, really fascinating. And your point that many folks who are prescribed this medication just sort of keep it as assurance of some kind. That seems like there's something happening there as well.
Like the epidural, like keeping that on your back.
Yeah, absolutely. Other folks, especially we've got a lot of students in the audience. Here's your chance to learn from a scholar in the field. Oh, I see a few coming up. Irmak, would you like to give voice to one of these?
Yeah, absolutely. So one question that Karina had is, how did you navigate studying a topic that is so tied to sadness?
That's such a great question. It's one that I've had quite a bit. It's a little bit hard to answer. I think the way that I experienced this research and these stories was not overwhelmingly with a sense of sadness. I felt instead that it was a gift that people were able to share their stories with me, and it really transformed my own orientation to my mortality. It made me think a lot about death in a way that I think was productive for me as an individual. I definitely did cry sometimes with people, but I didn't necessarily experience the topic as an overwhelmingly sad one. I've done work on a lot of emotionally difficult topics, and this project didn't feel like sort of heavier than others, if that makes sense. And I think what it shows is that death is sad, but it's not just sad, and it teaches us a lot of other things about our humanity, and many of the deaths that I was hearing about were actually like really beautiful and positive deaths, and so that changed the emotional valence of some of the stories. So it's very complex. I don't want to say that it's not sad, but I felt, I guess, very enlightened by hearing about the stories as much as I felt saddened by them.
Thanks for that. And I think we've got two other questions in the chat that I see as pretty related. So I think I'm going to try to synthesize them for you. So Luke is asking about some of the particular rules, especially regarding specific ages or age requirements for medical aid in dying. Because one of the slides mentions conscious adults can make the choice. So that's a question about, who makes that distinction and is age part of it. And Talia is also wondering what the limitations are, or are there strict parameters on sort of who is eligible and how someone obtains medical aid in dying?
Yeah, so adult is defined as 18 years or older. There are, I think Belgium may permit medical aid in dying in some instances for terminally ill children, but don't quote me on that. They're definitely much more permissive than the US. US and Canada don't allow this for children. And that is kind of related, I think, to our sort of legal structure for US medicine, children aren't considered autonomous to make their own medical decisions. So so this is just kind of an extension of that. In terms of other parameters and regulations, there are a lot of boundaries, and I didn't have time to go into that in this talk, but you have to be able to self-administer the medication, and that often rules people out with certain kinds of neurodegenerative disorders who might not be able to give themselves the medication. There are workarounds for that. I mean, there's some interesting legal analyses about whether or not you can put the medication into a feeding tube, and some lawyers have argued that you can. But this is why some people have said this law was really made for cancer patients, where there is a clear 6-month trajectory that might be a little bit difficult to tease out for other kinds of conditions. And it's also why Canada, in part, decided to give the option of physician administered medication, because they didn't want to exclude patients with certain kinds of conditions from having this option. So yeah, there are quite a lot of limitations.
And that makes me wonder too, knowing that you've worked with advocacy groups, it seems like primarily folks who are advocating for the right for medical aid in dying. I wonder if, I'm thinking especially of like disability advocacy, if there are folks who are reluctant to pursue medical aid in dying for like, because of the sort of history of eugenics related to things like disability.
Yep. Disability rights groups have been some of the most vocal opponents. And I did interview a number of advocates from the disability rights world for this research, for precisely the reasons that you talk about. There's this worry about devaluing the lives of people who are dependent on others for everyday care, and also concerns about a slippery slope. And if we make this option available, then will they try to kill us off too? I mean, I'm kind of simplifying that discourse, but that's sort of what the worry is. Yeah.
Folks who are left with us, I know that many of you are off to class or the next thing, but any other pressing questions?
I'm actually going to butt in really quickly with a question, and then it looks like Teja also has a question.
Great.
I would love to hear a little, I think you touched on it briefly, but hear a little bit about how this like scripting death has been affecting caregivers. I'm especially thinking about caregivers who themselves might be elderly, ill, disabled, or restricted in financial or social ways.
Yeah. So, I mean, two things. The caregivers that were mostly helping the patients that I interviewed in this sample, they were not sort of old and infirmed and disabled. These were, many of the deaths that I heard about were people in their 60s and 70s, and their caregivers were quite healthy and vital. And so I don't, I'm sure there's more of a range out there, but I can't really speak to that side of things. I think that there's a real opportunity here for caregivers to be much more involved in death than they otherwise would. And that can be good and it can be bad. I mean, it depends on the relationship between the two people prior. And so, in cases where someone came from a really strong support network and with like really positive relationships with caregivers, often these deaths would intensify those relations. And if there were kind of frayed ties going in, there were often frayed ties going out. And, one of the deaths that was recounted to me was just really, it was really horrendous, because there was a like tension between the patient's best friend who knew her wishes and knew what she wanted, and the family members who kind of tried to thwart those from being implemented. So it was not always harmonious by any means.
Yeah, it seems like a very tricky landscape to navigate for sure. I think we're going to take one more question. So Teja, you can share your question with us.
So I guess my question is kind of tied to like a little story, but like my great grandma, like she came down with pneumonia when she was like 95 or something. And so she really didn't want to live on like tubes or like a life support machine, but none of her family sort of like listened to her. So she ended up, how my parents described it to me was she ended up just holding her breath until she passed. So I guess my question is sort of like, where did you see kind of the line being drawn for certain people, like for patients with terminal illnesses, about like when they were essentially like medically ready, I guess, to have the conversation about medically assisted dying, or like when did like physicians keep trying to push for like more, I guess, care options rather than bring up the conversation of assisted death?
Yeah, I mean, so to answer your question sort of briefly and a little bit tongue in cheek, often too late. So often they decided they were ready or were made to wait until it was too late, because there's this 17-day waiting period to go through the whole process. And this is part of what some of the more recent modifications to laws in some states have been trying to work against, and reduce the amount of time that patients are made to wait, because I think many times patients will be told, oh, you don't have to worry about that yet. You know, you're not there yet. But by the time they actually would worry about it, sometimes there wasn't enough time. And this timing became a really tricky thing to navigate. One of the hospice nurses that I interviewed presented it like the patient who she helped died at the exactly right time, because she was right on the cusp of when she was going to naturally like really start to decline and enter a period of slow active dying. And so there was this sense that kind of like there's a right time to do this when you're about to really go downhill and lose quality of life. But that can be very hard to predict. And sometimes people didn't want to take any chances, and so did it maybe sooner than they really thought was ideal, because they didn't want to lose the capacity to swallow, or they didn't want to lose help from caregivers. So like the timing of it is really fraught, because no one can ever really know how much more time they have, right? So so that was a really kind of interesting dynamic with this.
Thank you so much, everyone who stuck around to the very end, and of course to Dr. Bookbinder for an incredibly engaging talk and really important research. So we can give her one more virtual round of applause for an excellent talk. And I will just very, very briefly share that we do have another speaker lined up for the spring. Well, two more. But our next speaker is Dr. Daniel Romeo Suarez from Vanderbilt University. He'll be joining us to talk about poetry and cancer in Latin America. So I hope that you'll join us again soon. But in the meantime, please be in touch with us if you have any questions about this or anything else. And thanks again, Dr. Bookbinder. This was a true delight.
Thanks for coming.
Thanks, everybody.